Welcome everybody here. I'm so glad to see so many folks here. This is such an important topic, something that is not typically recognized or discussed. It's the hidden epidemic of fetal alcohol spectrum disorder. And you may think you know some stuff about this, but I know that you are going to learn an awful lot today from our presenters. Before we get started, I really haven't taken the opportunity often enough to thank the people who are backstage for us. We have the amazing Chris Hall, our program manager for CECE, and Michelle Cody, our staff assistant / coordinator, who is also incredible. And then, of course, we have Dave Dadiego and Lee Cody, who help us with all of the production here. And so I see Eileen is clapping her hands, and we couldn't do it without all of you. So thank you for helping us today. And it is my sincere pleasure, I'm really excited about this, Kelsey, to introduce Kelsey Teagan, who will be leading us on this journey. She is an advanced standing student in the School of Social Work and a Maine trainee. So Kelsey, you ready? Okay.
Excellent. Thank you. Awesome. Thank you so much, Shelley. So hello all, and welcome to the University of New England Centers for Excellence in Collaborative Education event. In conjunction with the Maine Leadership Education and Neurodevelopmental and Related Disabilities Program and FASD Maine, we're pleased with the opportunity to present the hidden epidemic, exploring fetal alcohol spectrum disorder. We will begin shortly, but while we wait, please help us get the conversation started by clicking or scanning the QR code to get our word cloud activity slide.
Thank you, Kelsey. You can access the poll in a number of ways. You can use if you have an iPhone, you can use your camera to scan the QR code, which will take you to the website. Or you can
please feel free to put your name in the chat and let us know where you're from and what program you're involved with. We'd love to welcome everybody here.
Wow. Hey, everybody. This is Connie Mazowski. You'll be hearing from me later. I am with FASD Maine, and I thought I'd talk a little bit about some of the things I'm seeing in this word cloud. What a great word cloud. Everybody is weighing in. Thank you so much. I'm seeing a lot of people understand the stigma involved with an FASD diagnosis, and the fact that like mother is very large. I think that has a lot to do with the stigma.
I agree, Constance. I think that mothers are often blamed for things that happen to children, and in the case of fetal alcohol spectrum disorders, that is very pronounced. So thank you for noticing that. Shame for mother is in there. I think it's very powerful.
Yep, and it shouldn't be that way. So little education is getting out there about how to diagnose fetal alcohol, what to do about it, and how to prevent it. That we just need to smash the stigma and get on with learning about it.
Well, that's one of our goals for today, and thank you all for being here. And I think it's in many ways, a form of harm reduction as we begin to be aware of this issue that I notice also on the word cloud. It's unknown, unrecognized, that people just don't know about it. And if you don't know about something, you can't do anything to prevent it. And that's what we're doing here today.
That's right. I see some, compelling things, developmental problems. That is certainly a lifelong aspect of fetal alcohol. The term fetal, it talks about the origin of the condition, but a lot of people don't realize that it doesn't go away. But there is a lot that can be done in the early years and lifelong to help support people with fetal alcohol spectrum disorders and to support families as well.
Thank you, everyone. Shelley, are you ready to move on?
I think we can. And I'm really excited about the range of people who are here today. Welcome our ABSNs. Lovely to have you here. Okay.
All right. So before we start, I think it would be interesting to kind of review our objectives for today's event. So our first objective we'd like to discuss is hopefully our goal for our presentation today is that students will gain an increased knowledge and understanding of the origins and scope of FASD, its cognitive and physical impairments, effectiveness of prevention, early diagnostics, and the need for interdisciplinary intervention for children and systems affected. Next, we'll discuss, we're hoping that students will receive information and be able to identify the need for the FASD Respect Act and how they can become involved in social policy efforts by supporting and advocating for the radical improvement of services through a systems of care framework that provides funding for education and prevention for families in need. Lastly, our goal today is that students will learn from families impacted by the challenges of FASD and gain insight into their role as future professionals to facilitate harm reduction strategies by remaining curious, challenging assumptions, and having courageous conversations around alcohol use. And we'll be highlighting certain competencies in communication and teamwork. Excellent. So with a mission to increase awareness and prevention for fetal alcohol spectrum disorder through education of families, providers, educators, and community stakeholders, and by providing resources to make services and support accessible for those individuals and families affected by FASD, it's my pleasure to welcome today's guest presenters. First, we have Madonna Mooney. Madonna is the co-founder of FASD Maine. She is a former nurse and teacher with a sibling of an adult with FASD. And Madonna's work focuses on providing FASD education and building collaborative connections with existing organizations and agencies such as AUCD/the LEN program, Maine CDC DHHS, and the Child Development Services, as well as recruitment for the HRSA Safe Choice Learning Collaborative, the year-long FASD training for providers and staff for FQHSs. And Madonna's work with FASD also focuses on building access to high-quality FASD training and support Maine residents impacted by the disorder. Next, we have Constance Mizulski, and Constance is the co-founder of FASD Maine. She focuses on the passage of the FASD Respect Act, which is a vital federal legislation, works to adoptive and foster community, and oversees popular FASD book giveaway programs for clinicians, parents, and foster parents. Constance focuses on outreach to the media about the hidden epidemic of FASD and its effects on our society, leveraging more than 20 years of experience in media relations and marketing. She also runs a lively FASD Maine Facebook group, which you are all invited to join. Before adopting her two children, Constance ran her own public relations practice as a vice president at public relations for Lewis, Paul and Partners. And earlier in her career, she lived and worked in Europe for Hewlett-Packard. With her husband, she supports high impact projects and programs that promote early diagnosis for FASD and better life outcomes for people and families affected by FASD. And lastly, we have Shannon Corey. Shannon is the co-founder of FASD Maine. She is the director of volunteer services at Midcoast Hospital and a mother of two young adults with FASD. Shannon lives in Brunswick with her husband and two sons and two dogs. After consulting with many medical professionals in Southern Maine for the root causes of challenging behavior her sons were presenting at school and at home, she finally met someone that pointed them in the right direction. Her work centers around FASD advocacy, increasing awareness about the invisible disability, and the passage of FASD Respect Act. Now it is my pleasure to welcome and turn it over to Madonna Mooney of FASD Maine.
Thank you, Kelsey. And thank you, Len and CECE, for inviting us to speak today. For inviting us to speak today to share this vital information about fetal alcohol spectrum disorder. And my slides got away from me. I want to start by saying, as you can see, you all play an essential role. In your work, you will see children who are at greater risk for prenatal alcohol exposure and fetal alcohol spectrum disorder. You have the ability to build safe and trusting relationships with these children and families, And this is going to open the door to intervention that could alter the trajectory of a child's life. Okay, so what we'll cover today. What is fetal alcohol spectrum disorder? Why is it so prevalent yet rarely diagnosed? Why is prenatal alcohol exposure, PAE, so damaging to a child? How does it show up in children and how do we find them? And what can we do to help these children and families? First, I would like to share a brief overview of our awareness of FASD in the US, starting almost 50 years ago. The first article was published on the effects of prenatal alcohol exposure. At the time, we thought only heavy alcohol use during pregnancy harmed the developing fetus, and we called it fetal alcohol syndrome. By 1977, dentists are discussing the dental issues and craniofacial abnormalities that may occur in children with prenatal alcohol exposure. 1981, the Surgeon General's Bulletin is published in the New York Times, stating, "Do not drink if attempting to conceive during pregnancy or breastfeeding." By 1996, again, we know there is no known safe amount of alcohol use at any time of pregnancy, that it causes a spectrum, a range of disorders. 2015, we know that FASD is much more prevalent among foster and adopted children, and that it is largely misdiagnosed and undiagnosed in this population. Finally, 2022, we know, despite years of research and public health campaigns, the latest CDC data states that 1 in 7 pregnant adults drank alcohol in the past 30 days, and 1 in 20 binge drink. That's 4 or more drinks. So why is prenatal alcohol exposure still so prevalent? And why does FASD remain an invisible, undiagnosed, untreated disability? Alcohol is a complex issue in this country. It is a legal substance. It's considered less toxic than illicit drugs. We have cultural denial around alcohol use, stigma around prenatal alcohol use. We don't want to ask and we don't want to tell. Many children with FASD are in foster care and adoption. We don't have accurate maternal histories. Only 10% of children with FASD have facial abnormalities, and we're not really finding them. Developmental and behavioral problems are often not associated with PAE, prenatal alcohol exposure. And many providers are misinformed and condone light alcohol use or are uncomfortable screening for PAE. And this brings us to an American Academy of Pediatrics provider survey. You can see here that most pediatricians suspected they had a child with an FASD. Almost half were unfamiliar with PAE screening tools, and almost a third lacked training in diagnosing specific FASDs. Very few felt comfortable with their knowledge of FASD. Fortunately, the AAP has created an online FASD toolkit to educate providers. So what is fetal alcohol spectrum disorder? First, I want to mention that there are different protocols used to diagnose FASD, depending on the country or the various clinics in this country. And there is more information about this in the resources attached to this presentation. So FASD is the umbrella term under which there are specific diagnoses. These diagnoses cover the range of adverse physical, neurocognitive, and behavioral effects caused by PAE. PAE occurs when the mother drinks alcohol during pregnancy, and alcohol is especially destructive to the developing brain of the fetus. Brain injury from prenatal alcohol exposure is lifelong and irreversible. However, early intervention and family support greatly improve outcomes. So here are the criteria for the diagnosis under FASD. Prenatal alcohol exposure at any time during pregnancy, central nervous system dysfunction and brain abnormalities. For example, there may be microcephaly, memory, executive function, or self-regulation issues, growth deficiency, that's height or weight, at or below 10th percentile, and facial abnormalities, which are smaller eye openings, a smooth philtrum, which is that groove beneath your nose, and a thin upper lip. Only the first two criteria, prenatal alcohol exposure and central nervous system and brain abnormalities, are required for a diagnosis under FASD. This is the majority of individuals with an FASD. The other two criteria, growth deficiency and facial abnormalities, occur in fewer individuals with an FASD, and facial abnormalities are actually very rare. So here we have a chart of possible diagnoses under FASD. You can see across the top the 4 criteria. On the left, the possible diagnoses. We'll start with fetal alcohol syndrome, FAS. You must meet all criteria. Partial fetal alcohol syndrome, PFAS. You can see here only some facial abnormalities in CNS dysfunction and PAE. An alcohol-related neurodevelopmental disorder, ARND. No facial abnormalities or growth deficiency, but you still have moderate to severe central nervous system dysfunction. And finally, you can see here in parentheses, ND-PAE, neurobehavioral disorder associated with prenatal alcohol exposure. I included it here because it is found in the DSM-5. It is a diagnosis that covers all of the above diagnoses, and you can read more about that in the resources. So as you can see, facial abnormalities so often associated with FASD are only the tip of the iceberg. Only 10% of individuals with an FASD have any facial abnormalities. The greater majority do not. So this means that most individuals with an FASD have a hidden brain injury. They may have normal Bayley developmental scores as infants, an average to low average IQ, yet also have many of these deficits: auditory processing, sensory processing, and sleep disorder, severe executive function deficits, adaptive function, self-regulation, memory and attention deficit. They are expected to perform and behave at home and at school as if they do not have a brain injury, and to do so without the intervention, accommodation, or support they deserve. The good news here is that these deficits can be clues to help us accurately diagnose these individuals. So again, children are referred not because of a diagnosis of FASD, but because they have learning and behavior issues, usually in these domains of self-regulation, neurocognition, and adaptive skills. So we know what FASD is. We know the diagnostic criteria. How prevalent is FASD? You can see here, FASD is the most common cause of intellectual disability and birth defects in the US. On the left side of this graph, you can see a number of well-known disorders: spina bifida, Down syndrome, autism spectrum disorder. You can also see on a scale of 0 to 5% prevalence that FASD is about 2.5 times as common as autism spectrum disorder. We know this because of a study published in 2018. Over 6,000 first graders in 4 different parts of the country were evaluated for FASD, and they found that 1 in 20 first graders had an FASD. So why is FASD so prevalent? Unfortunately, we have a lot of opportunity for prenatal alcohol exposure in the US. This is that CDC data from 2022. 1 in 7 pregnant adults report drinking alcohol in the last 30 days, and 1 in 20 binge drank, in this case, 4 or more drinks in one occasion. The demographic most likely to drink during pregnancy: white, college-educated, higher income, age 35 and older. And this is CDC first trimester use, excuse me, when most adults, when most adults do not know they are pregnant. Almost 20% of pregnant women reported drinking alcohol in first trimester, and 10% report binge drinking. Here in Maine, CDC data, as a state, Maine's rate of alcohol use among pregnant adults in the last trimester is 10%. However, you can see here in 5 of our 16 counties, the rate is at almost 20, up to the highest rate of 32%. Almost 1 in 3 in Cumberland County. Those more likely to use alcohol in the last trimester, here in Maine, age 35 or older, income greater than $60,000, greater than high school education, insurance other than Maine Care, and these are intended pregnancies for the most part. Another source of data regarding prenatal alcohol exposure in Maine, the Substance Exposed Newborns Report from the Annie E. Casey Kids Count data. We had 901 substance-exposed newborns in 2020. And every year since 2013, there have been 850 to 1,000 substance-exposed newborns reported. And remember, these are only the reported newborns. We also know that FASD is prevalent in foster care. This is data from an FASD clinic at the University of Washington, where they have seen thousands of children diagnosed with an FASD. The rate of FAS among foster children was 10 times the general population. 70% of the children with FASD were no longer in the care of their birth parents, and on average, these children had 3 out-of-home placements. Here in Maine, over 1,300 children went into foster care in state fiscal year 2019. Over half of these removals were due to parental substance use, and alcohol and heroin were most common maternal substances. And 50% of all children removed were under age 5. From this same report, we can see by county the percentage reported alcohol as the primary maternal substance. You can see the very high rates in 5 of our counties. Also, in every county but one, there were at least 2 other substances reported, most often heroin, cocaine, and methamphetamines. So we know concurrent use of drugs and alcohol is common, not the exception. In this National Survey of Drug Use and Health report between 2005 and 2014, over half of pregnant women who used opioids non-medically binge drank, in this case, 5 drinks in one day, and there's a much higher rate of unintended pregnancy in this population. The national norm is 50%. So we know prenatal alcohol exposure is a problem, but why is PAE so destructive to the developing fetus? We have a perfect storm of factors. The placenta offers no protection. It is not a barrier to alcohol. Alcohol is a teratogen. By definition, it damages the fetus and causes birth defects. Alcohol is especially destructive to the fetal brain. It kills brain cells, alters the neurochemistry, plasticity, our ability to learn throughout our lives, the myelination, that nice fatty insulation on the circuitry of our brains, and the migration of cells during fetal development. Finally, elimination of alcohol from the amniotic fluid is only 3 to 4% the rate of the mother. This means increased level of exposure and duration of exposure for the fetus. So here we can see graphically the effects of prenatal alcohol exposure on a child's brain. On the left is a child with an FASD. This child has FAS. And on the right, an unaffected child. This is sophisticated imaging that shows the wiring, the connectivity of this child's corpus callosum, that crescent-shaped, very dense bundle of nerve fibers connecting our right and left hemispheres of our brains, the information superhighway of the brain. And you can see how stunted and how disrupted the connections are in the affected child. When we look at the MRI, again, the affected child on the left, you can see they have a smaller brain overall and underdeveloped brain parts. You can see the smaller corpus callosum, and you can understand how alcohol exposure causes so many struggles for these children and families. So we know there does not have to be heavy alcohol exposure to cause the brain injury of FASD. We know any alcohol use can cause moderate to severe brain dysfunction. Most children with an FASD have average to low average IQ. However, the diffuse brain injury of FASD causes uneven deficits, where a child may have high verbal IQ, yet low adaptive intelligence or impaired attention or executive function. So despite average IQ, many do not have the capacity to apply their intelligence to everyday functioning at home or at school. And we'll see examples of what this might look like in a moment. Here are some histories suggestive in the case of a child with PAE FASD: early placement in foster care and adoption, maternal substance use of any kind, including nicotine, the child or sibling born with a positive urine tox to other drugs, a sibling with a diagnosis of PAE or FASD, developmental delay, early childhood behavioral and school difficulties, early aggression, many of these kids get kicked out of preschool or kindergarten, and multiple psychiatric diagnoses. So remember, many providers are not aware of FASD or trained in diagnosing FASD. So many of these children are misdiagnosed or have incomplete diagnoses and receive ineffective treatment and support and unnecessary medication trials. So these are disorders that are commonly found with FASD and considered early indicators: sleep disorder, auditory processing disorder and hearing loss, sensory processing disorder, ADHD as a cause from brain injury, where medications may not be effective that you normally use with ADHD, problems with self-regulation, and short stature at or below 10th percentile. So this is what these may appear to be in children with FASD. Mild or global developmental delays, poor exploration of toys, delays in early feeding skills, extended feeding times, poor habituation, difficulty calming down or getting to sleep or staying asleep, delayed impaired fine motor or gross motor, and delayed acquisition of language. These children are easily overstimulated, have a low frustration tolerance, and have tantrums beyond early childhood. Impulsivity and aggression, over-friendly with strangers, which of course is a safety issue, poor understanding of cause and effect, they may appear fearless, anxiety, difficulty with transitions, poor working memory, and attention deficit and hyperactivity. As these children get older and into adulthood, their inability to grasp abstract concepts and their executive function deficits become much more apparent and cause serious challenges in their lives. So difficulty with concept of space, time, money. Imagine trying to hold a job when you can't manage your finances or your time. Difficulty generalizing and learning from mistakes. Reward consequence systems we use in schools really don't work well. Difficulty with sarcasm and jokes. Imagine the difficulties with social interaction. Poor judgment, impulse control, planning, and organization. Again, the prefrontal cortex damage. And these children are very gullible and vulnerable to manipulation by peers. They get into a lot of trouble because of that. And they have difficulty with math, despite an average IQ. So, because of the brain injury and deficits of FASD, it's important to consider the developmental age of the child. Here we have an 18-year-old who may have great expressive language, no facial abnormalities, normal height. They look and sound like an average 18-year-old. Yet their ability to keep themselves safe, to navigate the demands and responsibilities of daily life, to have a successful school experience is compromised. And it may be that of more of a second or third grader. So here we have a trajectory of unsupported FASD. With FAS in particular, suicide is the #1 cause of death. Life expectancy is 34 years. With FASD across the spectrum, suicidal ideation among adolescents is 5 times the national norm, and serious suicide attempts among adolescent males is 17 times the national norm. These kids have disrupted school experiences, including bullying, history of confinement in jail, prison, in our juvenile centers. Many have drug and alcohol problems, and at a very young age start to have trouble with the law. When you think about the fact that these children are more gullible, easily manipulated by peers, have impulsivity and judgment issues, you can understand this. But we can help. Any child with possible PAE should receive adequate assessment, including audiology, OT, neuropsych eval. The parent's report is critical to fully capture the child's challenges. We need to provide consistent structure, schedule, and routine. Identify and acknowledge and build on the many strengths these kids have. Keep a behavior log to understand sensory threshold, social threshold, to prevent that overwhelm. Bear in mind the child's developmental age, especially in early childhood, is usually half their chronological age. And always think brain. This is not a bad child. This is a child with a prenatal brain injury who needs our guidance and accommodation. And monitor the child for emergence of developmental, social, cognitive issues so common in children with PAE. We want to mention Choline, a nutritional supplement that has been studied and used for years as a nutritional intervention in early childhood to mitigate the effects of prenatal alcohol exposure. The information here is from a study published in 2020. You can see here that choline improved function in many areas, and choline is actually included in prenatal vitamins in some other countries. Finally, we have protective factors. FASD-informed providers, we have to educate ourselves, teachers, parents, the court system. We need early diagnosis and intervention. Relationship with supportive and informed clinicians, a good medical home. Our parent support and training has to be there, and respite. We need them to get brain-based approach training, such as families moving forward. Caregiver strengths, good diagnostic understanding of FASD, nurturing and attuned to child, ability to provide structure and high level of organization, and of course, a stable home environment and limited foster placements. So thank you. And now I am going to turn it over to Constance Mazelski, who will tell us about the current federal legislation to help those affected by FASD. Thank you.
Thank you, Madonna. I'm Connie Mazelski, and I'm here to make a public service announcement on behalf of the FASD Respect Act. My child and my family suffered because our systems of care were not and are not FASD informed. This pervasive developmental disability affects every aspect of my child's life, lifelong permanent brain and body damage. Yet here in Maine, having an FASD does not qualify a person for early intervention, special education, or services. Even getting accurate diagnosis is impossible for most families with no FASD clinic in our state. For our family, diagnosis took 10 years. And everyone on this webinar can help. You are in a position to make positive change in our systems of care and education. What can you do? Well, number one is learn about FASD. You've already taken the first step. Thank you. And for the sake of the up to 1 in 20 children and adults living with FASD in our country, I encourage you to keep learning. Please join us on Facebook at FASD Maine and explore our website at fasdmaine.org. The second step, help change our laws. This one cannot wait. If the FASD Respect Act passes, there will be money for prevention on a national level, and each state that sets up an FASD interdisciplinary team can get funding. Over the past 18 months, Maine families have partnered with our members of Congress to co-sponsor this vitally important federal legislation. And I'm pleased to tell you, they were highly receptive to the need. Senator Susan Collins, Senator Angus King, Representative Shelley Pingree, and Representative Jared Golden all stepped up. Maine was the first state in the country to have all of our members of Congress on board, joining dozens of co-sponsors in the Senate and the House, a true grassroots bipartisan effort. Please contact your members of Congress. Ask them to help bring Senate Bill 2238 and House Bill 4151 out of committee and to a vote now. You can find out details and sample messages on the website for the national organization FASD United at fasdunited.com. If the FASD Respect Act isn't voted on this session, time will run out. You can call their offices, email them, or fill out a form on their websites. Believe me, the staffers listen when constituents passionately speak out. The third thing you can do is reach out to your professional organizations. FASD United is keeping a list of sponsors. If you are a dentist in training or dental hygienist, please ask the American Dental Association to support the FASD Respect Act. Future doctors and nurses can ask the American Medical Association to commit the American Academy of Pediatrics, the American Nurses Association. Studying to become an occupational therapist or physical therapist, we'd love to have the AOTA and the APTA. Social workers, you're good. The NASW has signed their support, as have the nurse practitioners, OBGYNs, psychologists, and addiction medicine professionals. And future teachers and educators, how fantastic would it be to have backing from the National Education Association, more than 2 million strong. Everyone, you are the next generation of professionals. You are the future. Soon you will be on the front lines, helping the growing numbers of alcohol and substance exposed children and adults. Thank you.
Hi, I'm Shannon Corey, and you may be wondering why fetal alcohol spectrum disorder, a disability as common and problematic as it is so often unrecognized. FASD is not part of medical curriculums. Very few medical or behavioral health professionals are learning about this. It is a condition that is clearly underdiagnosed in the US. How can you find something you're not looking for? Something you cannot see or measure? It is the missing diagnosis in the toolbox. And yet it is the #1 cause of birth defects and developmental delay in the Western Hemisphere. Think about that for a minute. And even if FASD does cross the rare professional's mind, It is often a last resort diagnosis. This problem is so pervasive, it should really be the first possibility that is explored, especially if you're seeing a child in foster care or that has been adopted. No matter what your course of study, you all will be seeing people with FASD, and it's vitally important that you learn the red flags and know how prenatal exposure to alcohol will manifest in your discipline. For example, all you dental hygienists or aspiring dentists out there, you're in a unique position because you will likely see your patients more frequently than the typical physician. At a minimum, you'll need to be looking for the obvious facial signs of FAS, which Madonna talked about earlier. But in the absence of those clues, recognize that facial deformities, mouth breathing, a small upper jaw, cleft lip and palate, soft enamel, rampant decay in cavities, or late tooth abruption, these are all clues to a possible FASD. As part of the healthcare team, you need to pick up the phone, call the pediatrician or the PCP, and express your concerns. Help other health professionals to correctly diagnose these patients early and for the best possible outcomes. There's an enormous burden of stress on families raising children with fetal alcohol spectrum disorder. These are among the most challenging children to raise. There was a 2013 study that analyzed the stress levels of parents with children with autism spectrum disorder versus parents of children with fetal alcohol. The results were that parents with raising children with fetal alcohol spectrum disorder were experiencing significantly higher levels of stress than the parents with children that had autism. The caregiver faces lifelong responsibility of raising a child with a developmental delay. They face isolation and loneliness. It takes a toll on your mental and physical health. You feel judged. Not many know what FASD is or what it means in your day-to-day life. In 2016, there was a study that asked parents what would help them in raising their children with FASD. Parents stated that improved knowledge and awareness from healthcare professionals, from teachers, and from society would really help. Specifically, parents discussed the lack of recognition of the symptoms, those red flags, the lack of understanding about what a diagnosis of FASD means, and the need to promote better messages of prevention. Siblings. They feel neglected and resentful of their brother or sister with the FASD. They're jealous about the attention they get. They're angry about being different from other families. They suffer with isolation and loneliness. They're embarrassed about their siblings' behavior or appearance. They feel guilty for even having these feelings of anger and resentment, or for not having a disability themselves. The individual living with FASD, they're often blamed and shamed for their condition. They're called lazy. They're told they're not trying hard enough, and they're frequently bullied. Just last month, Saturday Night Live aired a cruel and disturbing skit that portrayed an individual with FASD. He was mocked and laughed at for his struggles, and at the end of the skit, the mother of the character bragged, "He's like this because I drank during pregnancy." What other condition would it ever be okay to write a skit about that made fun of someone who struggled with a disability and then aired it on national TV? Would we ever laugh and ridicule the individual with autism, Down syndrome, cerebral palsy? I don't think so. It just illustrates how much more education and awareness we need around this topic. We're counting on you to be curious, challenge your professors to discuss FASD in your class, and know the red flags. Learn to have difficult conversations around alcohol use with your patients and their families. Be active and advocate. I just want to say something about the case study I created. It's based on my own personal life experience. My children were not diagnosed until they were in high school, and because of this, my family and children suffered. Sadly, our experience is not unique. This scenario has played out repeatedly in this country and will continue to play out until we recognize, diagnose, and implement early interventions for the best possible outcomes for these individuals and their families. Thank you. I'm now going to hand it over to Shelley, and she will take you through the case study.
Well, oh my goodness, I just want to thank all of our speakers. I feel like you were incredibly powerful and I've so much knowledge given to everybody in the room. So I'm excited to have folks break into the breakout rooms. And here is the case. You were part of an education healthcare team evaluating Sam, an 11-year-old fifth grader diagnosed with ADHD and anxiety. His mother, Carol, is concerned that despite treatment, Sam isn't showing much progress. He continues to have significant neurocognitive and behavioral struggles, including tantrums, difficulty maintaining friendships, poor executive functioning. He can't keep himself organized. He's distractible and emotionally moody and up and down. He's also very sensitive and kind and vulnerable to being taken advantage of by his peers. He cries at night because of bullying at school, and his friends are often 2 to 3 years younger than him in age. Carol notices that Sam plays wilder and sillier than his 11-year-old peers. As part of the evaluation team, you will review his history and discover he was adopted at birth. He had normal developmental milestones. He was in the 50th and 70th percentile of growth, but he was always a poor sleeper. He developed asthma early. He's suspended from preschool for aggressive behavior. He was hitting and pushing and crashing into peers. He had decent grades, but he was a very reluctant reader. He had difficulty writing, but he had strong expressive language, but weak understanding of what was being said to him. Slow auditory processing and poor adaptational skills, even though he is very, very bright. So we have prompts here for you. First of all, introduce yourselves to each other. Make sure someone is taking notes or at least remembering what each of your groups discussed, because we'll do a quick debrief when we come back. You'll have about 10 minutes. And these are just some prompts to think about. What do you know about Sam, especially in light of what you've learned today so far? What questions might you have for him and for his family? And last, but certainly not least, especially listening to our speakers, as a future healthcare provider, what suggestions might you offer to Sam and his family, and what more do you need to know? So it's time for you to go into breakouts, and I will let the magic be.
That's a very well taken point. I think a lot of children with an FASD do qualify or do wind up qualifying ultimately for special education. However, if they're trying to operate in a regular classroom or in a neurotypical environment where people don't understand the why behind the behaviors, then whatever interventions may be suggested may not help. And then other families aren't very sophisticated or savvy and won't know how to advocate to even get their child into the special education programs. So I think there's a lot of experiences like that out there. And, I think a lot of teachers may have training on autism, but FASD is different from autism, and it's different from, classic ADHD as well.
It is different, but a lot of kids with FASD do first get diagnosed with autism. Both my children have got the autism diagnosis, but I've had 2 psychiatrists tell me, your kids don't have autism. So that's how they'll get the services. They might have a diagnosis that doesn't quite fit, but it'll open a door.
Yeah, that makes sense to me.
Yeah. Carly had a great question about what would you like to ask it, Carly, or would you like to just have me bring it from the chat?
I can ask it. When we were in our group, we were talking about, we definitely realized that the fact that they're adopted was significant. Just kind of moving on from that question, but we were wondering if you can ask the family about whether they are given any information about the birth mother, anything preceding.
I can answer that. I mean, I was given the information that they had or what the birth mother divulged, but that was never part of what I received. And I understand why, with the stigma associated with it. It's a tough thing. Yeah. Or they might have not known they were pregnant either,
Yeah, a lot of times this information isn't captured, and for children in the foster system, somebody along the line may have known about prenatal exposure to alcohol or other substances, but it isn't necessarily conveyed to the foster parents or ultimately the adoptive parents.
Mm-hmm. Lydia, you had a point you wanted to make that I think is really critical. Would you like to lighten up here?
Sure. I just said that I'm a BHP and I work mainly with children with autism, but during my whole, it's like a 12 to 20 hour training, and we didn't touch on FASD at all. I actually wasn't really aware of it as much until I joined the LEND program.
That's an excellent point. Some people consider this really a social justice issue where this diagnosis is hiding in plain sight. And, many people that need services, not just as children, but later on, absolutely can't get them because they don't have a diagnosis that's recognized under law. And FASD in like Maine law, for example, there's only one mention of prenatal alcohol exposure in the laws. And so therefore, a lot of people are falling through the cracks.
And one final question, because we're coming to a close and I know folks have to get to class. Lori, Mac, nice to see you. You had a question.
Yeah, our group pondered kind of who would be the best person to approach this subject with a family, because some of us are kind of in a position of seeing a family once to do an evaluation. But if we suspect something, it doesn't feel appropriate to do that in a one-time evaluation. So what's the next step? Who is the best person to reach out to with that information or that suspicion?
This is Madonna. I would say that's where the idea of training across discipline comes in, that you'll get a neuropsych eval, for instance, and then that is shared. And we have a neuropsych person here in Maine who said, I make a great care plan, and then I can't find anyone who really knows what to do with it, including, there might be an OT, there might be an audiologist, there might be, but I think it becomes sort of a sit down. These families who have these children, who are not me, but Connie and Shannon could speak to that. But just to say, this is, as I mentioned, a neuropsych eval, at least there's something to work with, or a sensory processing, an OT eval, there's something to work with. And we may not have the diagnosis, but we can still treat what's going on with the information in our minds that this is also a brain injury.
Okay, so the next step is think about going for a neuropsych eval.
Mm-hmm. I don't want to prescribe anything, but that's where a lot of this.
I would have appreciated hearing if you felt or suspected, no matter who you were, and if you had just one interaction with me, I would have appreciated hearing that from anybody. Because the more I hear it across disciplines, the more it's going to resonate, and I'm going to learn about it, and I'm going to say, wait a minute, there's got to be something here. But that doesn't happen. Everyone's afraid to go there. Everyone's afraid to have that conversation. You have to learn how to have those difficult conversations around alcohol, and don't be afraid. Just focus on the child that needs the help. Come at it from there. It's not from a shaming standpoint. It's all about providing this child with the best possible outcome that they can receive. And waiting till high school is too late. It is too late.
Well, I don't even want to interrupt this conversation, but unfortunately we have to end. And I want to thank everybody for your participation. I want to thank the audience for listening and being curious. And hopefully we can do something here at UNE with all our health professions to learn more about FASD. We'll probably be calling you back at some point to have these conversations. And just make sure you submit your attendance. And I just want to point your attention to next week. We're going to have an amazing presentation about corrections health. And we're going to be meeting people who work for the Department of Corrections and people who live in correctional facilities and what healthcare and aging is like when you live your life out in prison. And then after that, Thursday, March 24th, we're going to have a really interesting presentation about the intersection of architecture and health. So I hope you'll attend those. Again, thank you to everyone. And we wish you all a great, beautiful day, and get outside. It is gorgeous. Thank you so much.